Most people believe that when a surgeon says, you need this operation, it must be true. The white coat, the equipment, the consent form sitting right in front of you, everyone in that room is completely certain. So you pick up the pen. Stop. Do not sign yet. I have spent over 20 years on the other side of that operating table. I have held human hearts in my hands. I have repaired arteries, fused spines, removed tumors, and replaced joints. And I am going to tell you something that most surgeons will never say out loud. Some of the most devastating outcomes I have ever witnessed were not caused by the disease. They were caused by the operation itself. My name is Dr. Faviemo, and today I am going to expose 6 surgeries that carry hidden, life-threatening risks for anyone over 60. Not because surgery is wrong. Surgery saves lives every single day. But because there is a conversation that almost never happens before that consent form is signed. A conversation about what the research actually shows. About what your body, at your age, can and cannot survive. By the end of this, you will know which surgeries to question, what alternatives exist, and the 4 questions every person over 60 must ask before agreeing to any major operation. Here is something that should be taught in every pre-surgical consultation and almost never is. The human body after 60 is not a slower version of the body at 40. It is a fundamentally different operating environment. Think of 2 cars, one with 30,000 miles, the other with 250,000. Same stress test, same load, you already know which one breaks down. Under general anesthesia, an older body works harder on every front. The heart strains to maintain blood pressure. The lungs take longer to clear the anesthetic. The kidneys, already filtering at 50 to 60% of peak capacity in a 70-year-old, slow down further. And then there is the brain. Post-operative cognitive dysfunction affects up to 40% of patients over 65 after major surgery. For some, it never fully resolves. They go in sharp. They come out different. Roughly 40% of adults over 75 show signs of clinical frailty. A frail body faces a fundamentally different surgical risk, regardless of what any single test result says. Before I get to the 6 surgeries, I need to tell you about Raymond. He was 74, a retired civil engineer, careful, never missed an appointment. 2 surgeons had already recommended spinal fusion for his chronic back pain. His wife sat quietly in my office until she looked up and said, "Doctor, his brother had the same surgery at 71. He went in walking. He came out in a wheelchair. He passed away 8 months later." That sentence has stayed with me for 6 years. We will come back to Raymond. Surgery number 1. Open heart surgery in frail patients. Open heart surgery requires your heart to be completely stopped. A bypass machine takes over while the surgeon operates. For a healthy 62-year-old, that is manageable. For a 76-year-old with kidney disease, cognitive impairment, and multiple chronic conditions, it is a simultaneous assault on every major organ in the body. In frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications. Stroke, kidney failure, prolonged ventilator dependency. Up to 15% of high-risk elderly patients do not survive the first 30 days. What most patients are never told. A catheter-based procedure called TAVIA can achieve comparable outcomes without stopping the heart or opening the chest. Less trauma, faster recovery, dramatically lower risk. Ask your surgeon, am I a candidate for a minimally invasive alternative? What does the outcome data look like for my specific frailty profile? Surgery number 2. Aggressive spinal fusion for chronic back pain. Spinal fusion for a cord being actively compressed, causing paralysis or loss of bladder control, can be absolutely necessary. I will not pretend otherwise. But elective fusion for chronic back pain in an older adult is a different matter entirely. A study in the journal Spine found a complication rate exceeding 40% in patients over 65. Blood clots, infections, hardware failure, adjacent segment disease, where vertebrae above and below the fusion begin to break down. More troubling, multiple studies show spinal fusion provides no better long-term pain relief than physical therapy and targeted injections. Same outcome, dramatically higher risk. A brilliant spine surgeon once told me, Dr. Faviemo, sometimes the best operation is the one you don't do. Ask your surgeon, what does the evidence show for physical therapy and epidural injections before we consider fusion? Surgery number 3. Major cancer resections in frail elderly patients. When someone hears the word cancer, the instinct is immediate. Cut it out. Remove it. I understand that completely, but the goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. Those are not always the same thing. In an 80-year-old with heart disease and reduced kidney function, a 6 to 10 hour pancreatic cancer surgery may technically succeed, and the patient may still die within weeks. Not from the cancer, from the operation. A landmark American College of Surgeons analysis found nearly 1 in 5 elderly cancer patients who underwent major resection experienced a complication the weakened body simply could not survive. Ask your oncologist. If we don't operate, what do watchful waiting, radiation, or targeted therapy look like for my age and health profile? Surgery number 4. Elective joint replacement in severely ill patients. For the right patient, a hip or knee replacement is genuinely transformative. People go from barely walking to keeping up with their grandchildren. But elective means planned. It means you have time. Time to ask whether this is the right moment for your specific body. In patients over 75 with 3 or more serious conditions, the risk is significantly elevated. Deep vein thrombosis, clots that can travel from the legs to the lungs, postoperative pneumonia, hospital-acquired infections. The question is not whether you should ever have this surgery. The question is whether a period of prehabilitation, optimizing your cardiovascular health and weight before the procedure, could dramatically reduce your risk. Ask your surgeon, what is a prehabilitation program and what is your personal complication rate for patients over 70 with my profile? Surgery number 5, carotid endarterectomy in low-symptom patients. This is the surgery most people have never heard of. And that is exactly why it belongs on this list. A carotid endarterectomy clears plaque from the arteries in your neck that supply blood to the brain, intended to prevent stroke. For patients who have already had a mini-stroke, the evidence is reasonable. But for patients with no current symptoms, even with significant plaque on imaging, a major Cochrane review found that in asymptomatic patients over 75, the risk of stroke or death from the procedure itself may equal or exceed the risk it was meant to prevent. The operation designed to protect you from stroke may carry a stroke risk of its own. Ask your surgeon, what does the evidence show for statins, antiplatelet therapy, and blood pressure control versus surgery for someone asymptomatic at my age? Surgery number 6. Emergency abdominal surgery. This one is different. You don't choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding. There is no time for second opinions. But knowing the risks before an emergency happens changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries 30 to 50% mortality in the most severe cases. Not because surgeons are unskilled, because an elderly body under sudden trauma fights on every front simultaneously.
The inflammatory response a younger body resolves in days can spiral into multiple organ failure in an older one. What you can do today? Do not ignore symptoms. Persistent abdominal pain, unexplained bloating, sudden changes in bowel habits, or dark blood in the stool after 60 deserves immediate attention. Catching problems early means treating them before they become emergencies. And have the conversation with your family now, not in a hospital corridor at midnight. Tell them your wishes. These conversations are not morbid. They are among the most loving things you can do for the people who will be standing in that corridor. Has a doctor ever told you surgery was your only option? Write yes or no in the comments right now. Or tell me which of these 6 surgeries surprised you most. I read every single one. Before any major surgery, there are 4 questions every person over 60 must ask. Write these down. Question 1. What happens if I don't have this surgery? If nothing urgent changes in the next 6 to 12 months, you have time. Time to think. Time to get a second opinion. Question 2. Is there a less invasive alternative for my specific case? Robotic surgery, catheter-based interventions, targeted radiation? Options that didn't exist a decade ago are now standard in leading hospitals. Ask what exists for you specifically. Question 3. What does recovery realistically look like for my age and health profile? Not the average patient. You, your heart, your kidneys, your medications, your home situation. Push back if the answer sounds rehearsed. Question 4. What is your personal complication rate for this procedure in patients over 70? Surgeons track their numbers. A confident, honest surgeon will tell you. If they deflect to national averages, that itself is important information. Now, I promised I would come back to Raymond. When I reviewed his full picture, his kidney function, his frailty markers, his cardiovascular baseline, I sat with him and his wife for 45 minutes and told him the truth that the other consultations had never reached. Raymond was not a candidate for spinal fusion, not because of his age, because of his frailty score and the specific pattern of his degeneration, which research shows responds comparably to non-surgical management. We built a program instead. Targeted physiotherapy. 2 rounds of image-guided steroid injections. A sleep optimization plan, because poor sleep was amplifying his pain, and a daily movement routine he could sustain on his own. 8 months later, he sent me a photograph. He and his wife walking along the seafront near their home. A walk they had stopped 3 years earlier. He was not pain-free, but he was walking. He was living. He was himself. In the note he wrote, there were 7 words I have thought about many times since. I almost signed that form without asking. A surgical recommendation is not a verdict. It is the beginning of a conversation. The surgeon holds the scalpel, but you hold the choice. None of this means refuse all surgery. Surgery saves lives. I have seen it. I have been part of it. The message is simply this: be an informed patient, ask the hard questions, request the alternatives, get a second opinion, if necessary, a third. Your age is not a weakness. Your questions are not an inconvenience. This week, not someday, this week, write down those 4 questions and put them somewhere you will find them. Share them with someone you love who may be facing a surgical decision right now, because there are people in your life holding a consent form and feeling like they have no choice. You can change that. What question would you most want to ask a surgeon? Tell me in the comments. I read everyone. If this helped you, please share it. Subscribe for honest, research-grounded information every week. The best outcome is always the one where you never need the operating room in the first place. Take care of yourselves, stay curious, and never stop advocating for your own health. This script is based on published research and clinical experience. It is not a substitute for your personal medical care. Before making any decision about surgery or treatment, please have a full and honest conversation with your own doctor. They know your history, they know your body. That conversation is exactly where good medicine begins.